All right, perfect. Hi, everyone. Thanks for coming to the Awake and Thriving podcast. Today, we have with us Dr. Sneha Gazi. She's a physical therapist that specializes in pelvic floor and orthopedics. Welcome, Dr. Gazi.
Thank you so much for having me on the show, Andrea. I'm really excited for it.
Yes, definitely. I went ahead and I looked at all of your background, your bio. It's very extensive. And you start off in a very artistic form, and then you come into physical therapy. So I'd love to find out or have the audience know where you started at and what brought you into physical therapy.
Sure. So my whole life, I've been a dancer. My mom is a dance teacher. The dance studio was in our basement. So I kind of grow up like moving a lot. I took gymnastics, ballet, tap, and jazz, brief period of time figure skating. So it was a very my parents always encouraged me to do a lot of movement, and I loved it. I loved being on stage. I loved, just in general, the art forms. And I've, danced extensively. I've done world tours. And then I remember coming into college, and my mom actually was like, I think right after you go to college, I'm okay with you taking off some time and you can just go and dance and do that professionally before you want to start a career in whatever you want to do. And I remember going into college, I was like, can't wait. I can't wait. I can't wait. I wish I could just do that before going to college. And she was like, no, I need you to get a degree and then you can go off. And, I was on a dance team while I was at NYU. I was dancing more than I studied. So it was great. But then halfway through college, so I wanted to do journalism. So I went into NYU to do a journalism degree. And I realized that, I felt it was a very bizarre, very, very weird thing where I felt like being a dancer, I couldn't help people every day in the way that I wanted to. And I wasn't able to really provide and create an impact. It was almost me being selfish that I wanted to be a dancer. It was a very weird concept that went through my head. And I remember looking into medicine. I remember I did a psychology degree and I was thinking maybe I should do a PhD and do some research. And then I came across the work of physical therapy and I was sold. I was like, this is movement. I get to move my body. I get to teach other people how to move their bodies. I get to work with dancers and athletes and have all of my experience as a person who has been moving her whole life extensively and teach people how to optimize that. And even for myself, I think I learned so much more about body control and awareness and balance and strength and flexibility by going through a 3-year doctorate and dissecting cadavers and learning so much so intensely about the human anatomy and how, as physical therapists, we call ourselves movement specialists. I think, it's the highest degree of understanding the human body with movement. And so I think I'm really blessed that all of those paths and all of those thoughts in my head brought me to this field and kind of made me where I am today.
So you work with a lot of athletes and women, it sounds like?
Yeah, I work with a huge general population. So I work from pediatrics. I have my ped stall for when I do telehealth with the little babies on the screen. So I work with babies all the way up to geriatrics and towards the whole lifespan. And my specialty is in orthopedics medicine. So that means anything related to the kind of the musculoskeletal system. So for anybody who has any kind of movement dysfunctions or aches and pains, that's where I can fit into the picture. And then of that, I am also specialized in pelvic health, which I know that we're going to dive into a lot today, and performing arts and sports rehab. So all of that is kind of like orthopedics is like an umbrella term that kind of fits in a lot of things like, pelvic health, performing arts, physical or dance medicine, sports rehab, and things like that. And so, and I think that it creates a really fun environment for me because throughout the day, I'll be treating, I'll have a little baby that has, a torticollis, which is their neck is kind of bent over and rotated to one side. And then my next patient is a new mom who has urinary incontinence. And then my next patient will be a 20-year-old male soccer player who sprained his ankle. And then I'll go see an elderly mom who has a frozen shoulder. And it keeps everything interesting because I'm always on my toes and able to kind of switch gears and just use all of the science that I know and then translate that into treating somebody in front of me who has something that they need help with.
So you do telehealth and then you do visits at
in-home visits,
right?
And yes, I don't have a clinical space.
And so when you do the telehealth, how does that work? Like, what do they do for that?
Interesting question. So prior to the pandemic, I only did in-home visits. So I'm located in New York City, And I live in Manhattan. So I service Manhattan, Queens, Bronx, and Brooklyn, and Jersey City, because I'm licensed in the states of New York, New Jersey, and Maryland. And so if there's anybody in upstate New York, or if there's anybody in like outside of Jersey, like city area that's like close to the bordering area of New York City, then I wouldn't be able to see them. But then after the pandemic, everybody had to change to telehealth for some amount of time when there was a lot of uncertainty. And so I basically converted a big portion of my patients into telehealth. And then when I would take on new patients, they would start and finish with me during telehealth. Basically from March until about July, I was primarily teaching through telehealth. And then after July, I think the clinic started opening up a little bit with a lot of precautions. I started implementing a lot of precautions with my in-home visits, which I still maintain to date. And so people became more comfortable. And now I'm back to basically all in-home visits, with maybe a day that I do some telehealth in the beginning of the day or the end of the day. And the telehealth it's interesting because when you're doing a physical therapy evaluation, people will usually think, I need to use my hands on you and I need to see what's going on. But there's a lot that we can do just by seeing and observing somebody, and then allowing the patient to bring more awareness into their own bodies and see what's going on with themselves. So what I mean by that is, for example, say that somebody is coming to me, let's just do a standard lower back pain. They've been sitting a lot during the pandemic, their chair is all out of whack, they're using their kid's chair or something and making a makeshift workspace for themselves. And they're sitting a lot, so they're experiencing a lot of lower back pain, they're busy, they're having homeschool, they don't have time to exercise. So what I would do in that session is firstly get them to show me their workspace. I'll do an ergonomic assessment. I can make sure everything is set up well for their unique bodies. I can take a look at what's going on with their spine. I can see that in the camera. Is there anything that I see that's maybe off with their range of motion? I can have them do a self-strength test and kind of report if there's a asymmetry from side to side, or I can use a lot of functional movements like squatting and pulling and lifting to kind of test their strength and see what's going on with their bodies. And then my favorite thing is to use, instead of using my hands to treat a patient, is using tennis balls, lacrosse balls, and pinky balls to do self-releases, because physical therapists usually don't have a physical therapist. So we use our environment, and I use my random like foam rollers and balls and the wall and all sorts of, or I teach my husband how to do a quick release on me. And he actually knows one of my favorite muscle releases that he needs to do anytime I get a little spasm. So I basically teach partners. So I get a partner on the screen or a family member on the screen, and I'll say, hey, this is what we're doing. This is what we're trying to accomplish. And I'll kind of guide them through anything that they need to do and kind of work through. So interestingly, it sometimes works even more efficiently in certain cases because it requires a person to not rely on my hands and really rely on themselves and trust themselves that they can go through this healing process without a lot of manual work. And if they do require any kind of adjustments or releases, that it might be possible to use an environmental thing or their family member or partner at home to do that for them. So, yeah.
Wow. So what kind of other physicians do you work with? Can people like self-refer themselves to you? Like they're like, I'm having an issue. Can I just see a physical therapist? Or do they usually have to be referred to you with like an MRI or X-ray as well?
So in the state of every state is a little bit different, but most states have direct access to some capacity, which just means that they can directly come to a physical therapist without a script of any kind for maybe a certain period of time or a certain number of sessions. So for example, in the state of New York, you can directly come and see a physical therapist for 30 days or 10 sessions, whatever comes first. And then after that, you need a script from a physician or from a doctor, any kind of an MD or provider who can refer them for that script. And states are a little bit different on what their laws are. So if anybody is curious, they can probably easily call up a physical therapy clinic who's somebody who's in their state and ask, what are your laws? Do I need a script to see you? Most likely the answer for the first evaluation in many states is no, you don't need anybody to come get referred to see you, because we are going through a very intensive training. It's a 3-year doctorate. So we have a lot of tools of how we can screen people in evaluation to see if they're actually a candidate for physical therapy or not. And then if they're not, we can actually tell them, we're actually not going to work together. You're going to go and be referred to XYZ to either get imaging or to get a surgical consult or do some other kind of procedure or intervention or screening tool in order to make sure you're cleared for physical therapy. So we have the capacity to do that screening. And in my practice particularly, I offer everybody, because it's also an in-home practice, so I have to physically go to that person and see them. I wouldn't want to go there and realize within 5 minutes that that person wasn't a candidate for PT. So what I do for everybody is hop on a 10-minute free phone consultation where they get to explain to me what's going on. And then I get to ask them a couple of questions to make sure that we're a good fit to actually start working together. And there are occasional times where I'm not, and I know that the person just had a car crash and I can't see them until they get that imaging for that particular thing to make sure they don't have a fracture, just to make sure that everything is okay before I can come and intervene into the plan of care.
Okay. So some people need imaging, but you can do an assessment and kind of figure that out. Okay.
Yeah. Usually imaging is necessary for acute issues. That tends to be the main reason why, like, for example, like I said, a car crash, an elderly person who falls, and somebody who's experiencing symptoms of concussion, somebody has a lot of red flags that we get to kind of screen, like a lower back pain that comes with, sensory changes around their glutes and their perineum. And then they're also having bowel and bladder changes. That could actually be something called cauda equina. And so that's not something it's an emergency. They need to go to the emergency room. And somebody might come to me just thinking that's lower back pain, but I get to ask these questions in the phone consult to make sure that this is not a big thing that we can't see each other yet for.
Okay. All right. Wow. I've never seen a physical therapist, or even, I'm not even sure. No, I don't think I've ever spoken to a physical therapist. So all this stuff you're telling me is brand new. So I love learning.
Great.
It's wonderful. Wonderful.
Fantastic.
And so if we can venture into pelvic floor health.
Well, very broad question. I do live events and webinars and Facebook Lives for like 3 hours on this topic. So I'll try to keep it real short. But okay, so what is the pelvic floor is probably a good question that we can start with.
Yeah.
Do you mind if I grab my pelvis model?
Please
Take
go
like
for it.
10 seconds to do that. I didn't think about taking that out yet. Great. Okay. So I'm going to pull out my pelvis model so people who are watching the video version of this can have a visual of what's going on. And you can kind of follow along if you're on the audio version of this, I'm sure, just kind of visually imagining things. So this is my pelvis. This is a little model of a pelvis. This is where you would put your hands on your hips, like right there. And then this is your pubic bone at the front. And then I'm going to flip this guy over. It's a her, actually. And then this is the spine, the lower back, your last two vertebrae in your lumbar spine. And this is your sacrum. And then this little guy right here is your tailbone. And then if I put him back in the front, all of these little things inside here that I kind of threw in are your things like your bladder, your uterus, your rectum, your fallopian tubes that all sit around here. So I'm going to get rid of those guys. And then I'm going to flip her this way. So these are my two sit bones. So if I were to sit, like we're both sitting on that hard part right under your tush, those are your sit bones. And then this is your vaginal opening and your rectal opening. And then everything that you see in red are muscles. They're muscles just like every other place in our body, like our glutes and our biceps and our quads, the muscles that make my mouth open and close, muscles that make my hand move when I'm talking. And that those are skeletal muscles. We have different kinds of muscles in our body, like cardiac muscle and smooth muscle. We can't tell our heart how many beats a minute to beat. That just happens. That's cardiac muscle. We also can't tell smooth muscle, like the food in our stomach, like go from stomach to small intestine to large intestine. We can't tell it to do that. It's all involuntary. But our skeletal muscle is what we can control, which what makes us move and function and do everything that we want to do in our lives. So just like that, all of these muscles that you see here are considered pelvic floor muscles that you can actively contract, actively relax, stretch, and strengthen, just like everything else, and move. And then the pelvic floor also consists of these little ligaments, which are basically like ropes that connect from one side of a bone to another that keep things in place. And then there are nerves and blood vessels, and there are, connective tissue called fascia, which if you can imagine like saran wrap that kind of goes in between and around everything and holds things into place. That's what like holds our body. Fascia is kind of like the thing that keeps us from going into
Or
the blip.
Spanx for the body.
If anybody follows the Avengers, it prevents us from going into the blip involuntarily, which like disappear into thin air. So all of those things are considered our pelvic floor structures. And then the pelvic floor muscles, like I said, are the ones in red here. And they kind of cover all the way from the vaginal opening all the way back to the tailbone, and then in between each of the sit bones. And so the purpose of the pelvic floor itself, so the reason why it's called the floor, it's like a bowl, right? So it's the floor because we're sitting on it, we're standing on it, we're moving on it. And it's a base that supports our head, arms, and trunk, our digestive tract, our reproductive organs, our vital organs like our heart and our lungs, our head, everything. And so one of the primary functions is to support us, to hold everything up. And then the other functions, because it's so close to these areas and these organs, is that it controls bowel, bladder, and sexual function. So that's why it's such a taboo thing, because we're talking about pooping, peeing, and sex. So people are like, oh, okay.
Like, yeah.
All right. No, don't talk about that, right? But it's a big problem. And a lot of people have issues with those things. And so that's how pelvic floor PTs intervene. And then I can go on and on and on. So I'll let you ask a question.
And so people that like need bladder slings, that's from a weak pelvic floor.
That could possibly most likely be from a weak pelvic floor. Bladder slings can be required surgically if you have a pelvic organ prolapse that is so severe that your organs, these little guys that I had on top. So this is, for example, like your rectum that sits like in the left side down here. And so typically, like a typical client that will come to me with a pelvic organ prolapse, there's many different kinds, but I'll give you a typical reason why somebody would come to me, is they've had a really big baby and they had a really long labor. They've been pushing for a really long time. They're also constipated and straining on the toilet a lot. So they're bearing down and pushing, and they go through labor, and then they end up having to either get like a vacuum assisted or a forceps delivery, where it's not just that the baby kind of comes out, but they just need an assisted delivery. And then after they give birth, they're like, I feel like a lot of pressure down there. I feel like things are almost like, it feels like something's falling out. I don't feel like there's a lot of things that are holding things up. So if you think of the pelvic floor, like we talked about all of those structures, there's like bones and ligaments and muscles and fascia and saran wrap that's holding everything up. Imagine that's like a trampoline, and a trampoline has just been like, had like a million kids jump on it for like 3 days straight. And so it just gets a lot looser and a lot weaker. And so things feel like it's falling down. So people will sometimes complain of like a bowling ball is down there and it's pushing downward. And sometimes the problem is that, and this is now me talking from a subjective place, is that because we've had such a male dominated medical field for a really long time, the first line of defense has been surgical consults and getting surgery for these things, when maybe that's not the first step for that particular person. Sometimes it is. There are certain reasons why that might be the case. But I see tons of people who have a prolapse, a first, second, and third degree prolapse, who can reverse that or at least be asymptomatic after pelvic floor PT. So you kind of learn how to re-engage your pelvic floor muscles. And just like all the other muscles in the body, you can strengthen them, right? So it's not like you can't do anything about it, because you can actively contract and you can actively relax. So when you do that naturally, you're going to build more bulk. Just like if you did bicep curls, 3 sets of 15, and every week you increase 2 pounds, you're going to have biceps that look like they're biceps. That's just what's going to happen with the human body. So if you practice and you learn how to do these efficiently and effectively, then it can actually create measurable change, both subjectively and objectively in people.
How long, I know this question is going to be different for everybody, but how long, say somebody has a prolapse 2, how long will it typically take them to get back to their normal? Or
yeah, it's a good question. And like you said, it's really hard, because I can have somebody who looks almost exactly the same as another person in terms of their symptoms and what they come to me for. And then they take completely different timelines for healing. And that could be a result of a various number of things. And one of the primary things is time. And especially if they're postpartum, how much demanding is their child for them? And how are they able to cope with taking care of a newborn plus themselves? And how are they able to juggle all of those things? So time can sometimes be the most restricting factor in all of this, which is why I'm a huge proponent of prevention and love talking about this. So that a lot of people pre-conception can learn about their bodies and learn that they can do a lot to prevent a lot of these things from happening, or at least try to. so that anything can happen, during the labor. And also caveat to all this is prolapse doesn't only occur during childbirth or postpartum. It can also occur for other reasons, or even later in life, like perimenopausally or postmenopausally as well, when somebody had zero symptoms before that. So it can appear later in life or even earlier in life. But the biggest risk factor is a vaginal delivery. So yeah, it's different for different people, but in general, I'll say that it usually takes about 4 to 6 weeks to see a lot of change in somebody. Maybe not completely there to their finish line, to how they want to feel, but usually 4 to 6 weeks is a good number, a good timeline to start to see that muscles are changing in their body. That's objective and a little bit more longer lasting. So that's what I would say is a general ballpark. But then from there, it depends on the person's goals, right? So if somebody's goal is, okay, I have a prolapse, a pelvic organ prolapse, there's a downward descension of the organs. And by the way, this can happen with your bladder, your urethra, the vaginal wall, your uterus, your rectum, and then some cases, even the small intestine. And they all have different terms for those things. It could be more than one. It could be a combination of a couple. It could be just one thing. So if somebody's goal, like I see a mom and they look exactly alike, and one mom says, I just want to be able to push my baby in the stroller across Central Park for 30 minutes, and I don't want to feel this pressure. Okay. And then another mom comes to me and she says, I want to run the half marathon later this summer. Her protocols with return to running and return to play and return to sport is looking completely different because her goals are different. So I'm going to be doing a lot of strength training and sports training with her, a lot of plyometric work with her that's going to be more translatable into her not having symptoms with running. Whereas and there's nothing right or wrong about what those goals are, because I meet them where they are at. And that's my goal, is to help the patient achieve their goals. So it looks different from one person to another.
From what I'm hearing, there's a lot more than just kegels for pelvic health.
Absolutely.
And there's also a question I wanted to ask you. You've probably heard of these, you've probably seen these, but they have weights for down there. Mm-hmm. Do those actually help? They have different weights depending on what you're dealing with. And if anybody doesn't know what I'm talking about, they have weights that you can insert into your vagina. Obviously you would clean those before, and you're supposed to keep them in there, clench your muscle for 10 to 15 minutes. And they're really popular. A lot of people say they have really good results from them. I tried them out. I thought I got a lot stronger. I wasn't really having any kind of major issues that I was like, oh, this has made a big difference. But I just I work out, and I was like, well, that's a muscle. Let me work it out.
Yeah, totally. So I'd say the answer to that is it completely depends on if you have an issue and what that issue is. So for some patients, their problem might be a lot of weakness at their pelvic floor muscles. And so doing a Kegel can be helpful when done correctly. So if somebody has weakness and they know how to do a Kegel correctly, and you introduce the weights and they don't have any other issues, like you might feel stronger, more stable, and you're building muscles, right? It's just like our example of doing 3 sets of 15 bicep curls every single day and increasing 1 to 2 pounds a week. Like, you're just going to get stronger, right? If everything else is fine. But then for some people, many of my patients actually have very tight pelvic floor muscles. They come to me with symptoms like scar tissue adhesions from tearing during labor and delivery, or even people who have nothing to do with labor and delivery. They're not even pregnant. They're younger, and they have pain with sex or difficulty with orgasm, or even people with a male anatomy who have a lot of pain with ejaculation, or pain with sex, or pain with urination. Those people might be presenting with tight pelvic floor muscles. And so for them, if you ask somebody who has a really sore and tight muscle to keep repeating the motion that tightens that muscle, it's doing the exact opposite. And so some people have this misconception, like you said, I have like an issue down there, let me do Kegels, it should solve the problem. And a lot of doctors, not knowingly, will also tell you to do that. And it gets them so much worse, and they're flared up and they're like, what the heck is happening? Mm-hmm. So that's why it's really important to get an evaluation, understand what your symptoms are, understand, like, a pelvic floor evaluation. I can also explain what that is in a little bit, but it helps me objectively check your muscles and see what's going on in a very safe space that you understand exactly what's happening. And then I get to give you feedback objectively with what I found and try to match that with your subjective symptoms, and then create an individual plan of care just for you. So that cookie cutter approach doesn't really work where, oh, do a couple kegels, you'll be fine. You won't pee anymore. Well, you might be having urinary incontinence because that muscle is super tight. And so when you sneeze, you are so tight, you don't even have the ability to contract and not leak pee all over yourself.
Wow,
So,
what you just said, I wouldn't have expected. So you can have urinary incontinence from too tight of a pelvic floor, and
yep.
you can have it from too loose of a pelvic floor.
Yep. And sometimes it's a combination of both, and it's a chicken or an egg situation. So, Andrea, if you were to hold out 2 gallons of milk in each hand, outstretched like this for like 30 minutes, and then you were told to put them down and then beat a 2-year-old in an arm wrestle, would you be able to beat them? The answer is probably not, because they're so tight and so fatigued, and you've been contracting them all this time that when you need to use that muscle, it's so fatigued, it's weak. It's a tight muscle that's become a weak muscle, or vice versa. So that's why it's important to really understand, where is the patient coming from? And sure, so for some people, that is the solution, to do the vaginal weights and do your kegels. And that's sometimes part of their plan. But what I say is, somebody needs to understand their full range of motion of their pelvic floor. There is a range of motion, albeit smaller and in a very private place, but there is motion there. And we need to understand, where are you in that motion? Are you always fully relaxed, or are you always fully tightened, or are you somewhere in between? And that's my job, to help somebody understand what that means for them during the session.
And I think a lot of women, they just associate their pelvic region with their OBGYN. And all the OBGYN does is, does the pap smear, does all that testing, and recommends kegels. Or you get recommended to a specialist for surgery. Because myself, I know of people that have had the bladder slings and all the prolapses, but they've never been recommended to physical therapy. They've just been sent to the surgical office. So having that option now, that's, I think, empowering for women, that they don't just have to go directly to get surgery for something like this.
Absolutely. And that's exactly what pelvic floor PTs do, is we really want to help you with your quality of life in a conservative way, where you don't necessarily need to get surgery or, expensive injections, unless you need it. Unless you need those things and it's really indicated, we'll try, for everything else. And, if you come to the doctor with knee pain, they're going to tell you to go to physical therapy, right? Like, as long as there's nothing torn, they don't see that there's like an ACL tear or something that you actually maybe need to get surgery for, they're going to send you to physical therapy. If something hurts or something feels off in your body, usually the first line of defense is, you got to do physical therapy. And then if that doesn't work, conservative treatment for 3 to 6 months fails, then you have to do surgery, or maybe get some injections or things like that. And I think that this area, it's the pelvis, right? But it's like, you saw how closely it is intertwined with your spine, because these are your pelvic floor muscles, and then your spine goes right here. And then these are your hip bones. These are your sockets where your hip bones come out. So a lot of people who have hip pain, who have back pain, it's like, it could be coming from the pelvic floor. There might be a chicken and egg situation happening there, where maybe there's pelvic floor dysfunction, and that's causing some of their other issues. And then even for physical therapists who have no idea about the pelvic floor, may not be screening them correctly, may not be asking the right questions, because they're like, oh, I don't want to talk about the pee poop sex thing.
Yeah.
That's kind of intimate. And so they might be missing this whole picture of something that's going on with somebody's body, when it's all connected. That's like going to the doctor or going to a physical therapist. And we're taught this in school. Somebody comes to you and they have shoulder pain. You take a look at the joint above and below that place. So I'm definitely going to take a look at your neck, and I'm definitely going to take a look at your elbow, because a lot of those muscles and ligaments and connective tissue are crossing over into other joints. So you might be coming to me with shoulder pain, but it's coming because your neck is cricked up like this. So if I don't take a look at take a little bit of more of a bird's eye view at what's going on, and I just go into this one place, I might be missing the picture. And so that's the problem with other areas of your body, where it could be something happening with your pelvis. Maybe it's not, but if you don't understand what's happening there, it's like completely cutting out a part of your body that's extremely important. I mean, your pelvis is what helps you walk and move, and you sit on it, and everything you do is really there. So it's important.
Yeah, it's very important. You spoke earlier about, what does a evaluation of the pelvic floor look like? Because for me, I think most women, the way they have their pelvis evaluated is in the stirrups at the OBGYN's office. So it's hard for me to imagine how would we get evaluated by a physical therapist for a pelvic floor?
Yeah, so there's no stirrups, there are no forceps, there's no speculum, there's nothing, there are no crazy things. It is there's always consent. The patient will be, given both paper and a verbal understanding of what is happening, and they have to give consent throughout the whole evaluation. It's not scary and it shouldn't be painful really, unless we're trying to figure out what's going on and we have to kind of press somewhere or turn something to evoke pain to get an understanding of what is the diagnosis. That might be the only time there is discomfort. But all in all, it's just the patient is laying down either on their side, on their back. The exam can happen intrarectally or intravaginally. It's one gloved finger that's lubricated. And then the physical therapist may first observe how the patient's skin and muscles and everything are around this whole pelvic area. So we're looking at this space to see what's going on. Is there scarring? Is there redness? Is there something going on there that we should be concerned about? And then I usually ask a patient to contract and relax, whatever they think is a Kegel, whatever they think is an opposite of a Kegel. And then I see what they're doing. Are they actually squeezing their pelvic floor? Are they just clenching their butt? Are they just bringing their knees together and squeezing their inner thighs? What are they doing? And then if they're comfortable with it, you get an external evaluation where I'm checking the muscles outside. And then you either get an internal, intravaginal or an intrarectal exam, depending on if you have the male or female anatomy and depending on what we're treating. What are we looking at? What's the main issue here? And then basically I'm checking the muscles in the different layers because you can see, so if this is the intravaginal, vaginal opening, if I flip this over, that's where I am. I'm just trying to figure out what muscles over here are affected and is there tenderness? Is there, just like a PT might be pressing on your back and going, is it hurt here? Does it hurt here? It's the same thing. So these structures are just accessed in a very intimate and weird place, right? So patients might feel uncomfortable, but the point of the evaluation is to make the patient feel as comfortable as possible. And usually they are, and usually, they have enough information, they understand why we're doing this and they want to get help. They're usually desperate because they're like, I just want to know what's going on. Do what you need to do to give me a diagnosis and a plan of care. So that's what I do. And I make sure on the evaluation, I'm explaining everything as we go along. And then at the end, I tell them what I saw and what the objective, evaluation came out with. And then what are we thinking in terms of our next steps? And usually on the first session, be able to take a look at their whole body. How are they moving their spine? How are they moving their hips? What's their muscle strength like? Because everything is connected. So I'm looking at all of that. And then I do the internal pelvic floor evaluation if they're comfortable with that. If not, it's an external evaluation. And then they get started with one or two things right off the bat that I know will be helpful for them, either for pain management or something that I think that they should start learning and, getting the hang of for a future session.
Wow. You're giving me some information I've never heard. I'm sure there's a ton of people that are going to listen to this that have never known that this was actually an option. I think a lot of women, once they have children, they think having incontinence or other issues in the pelvic floor is just unfortunately what happens, and you just have to live with it. So
yeah, and that's the thing, they don't have to. So all the stuff that people say, postpartum pain with sex or postpartum incontinence, postpartum constipation, all that stuff that happens, lower abdominal pain, C-section scar sensitivity, they're like, yeah, this is just going to go on, and that's just part of my battle wounds from giving birth to this beautiful child. And the thing is that, I think part of the big mission with pelvic floor PTs, because firstly, pelvic floor physical therapy can be, again, across the lifespan. There's pediatric pelvic floor PT, there's geriatric pelvic floor PT. Like I said, for people post-prostatectomy, like had a prostate removed, and somebody with a male anatomy, people who've had transgender surgeries and reassignment surgeries that have issues in there, and women who have female anatomy with postmenopausal issues. But then if you specialize particularly in the perinatal space during like prenatal and postpartum period, I think one of the big missions is to really empower a new birthing parent to say, it's okay to say that you have an issue that you want to fix. And it's not contraindicated or wrong of you to reach out for help, because I think most of the time the media And family and friends will just say, you got to live with that. That's just the consequences of it. And then that's just not the case. There's so much we can do.
Mhm. What does prevention look like for this?
Yeah. So, well, firstly, I think prevention starts with education, which starts with conversations like this. I also have a free digital series called Girls Gotta Know, which is on YouTube. You can see it on my website. Also, they're like little short, like 8 to 12-minute videos that are fun and educational, talking about various pelvic floor issues. So I kind of do what I just did right now with the camera and the model, and I'm explaining the anatomy and the different things that could go wrong. There's like pelvic floor 101, urinary incontinence, pelvic organ prolapse, pain with sex, and constipation are the 5 topics I kind of just chose because I just think they're very common. There's a lot more than that to pelvic floor PT, but I think learning, there are so many blogs out there that I have. I have my own podcast called Fit as a Fiddle where people can learn. It's a health and wellness podcast, so it kind of covers a broad spectrum of things, but there is a lot of guest speakers on there who do talk about the kind of pelvic health issue space. So I think the primary thing is if you have an issue, go and learn about it, go and research about it and understand what's going on. And don't take, you got to live with that from your medical provider as that's the end of the line for you. And then reach out to pelvic floor physical therapists who can educate you and give you information on what's going on. And it's like, for example, I got lots of people now, which is fantastic. I get tons of people now who will, like you, will say, I don't have an issue, but I'm in the preconception phase or in my first trimester, and I want to know what I can do to optimize my pregnancy and make sure that I'm setting up my whole body and my pelvic floor for an efficient labor. I'm planning on having a vaginal delivery. I want to learn how to push efficiently and make sure I can prevent a lot of these things. And so all of my session is a lot of education. I teach things like perineal massage that can prevent tearing and episiotomies. I teach partners how to do them for the mom. They're in their 3rd trimester, and it's easier for them to do it that way. I teach, like I said, from the evaluation, I teach people how to understand what is your full range of motion of your pelvic floor, because things need to come out and things need to come in. So when I say things need to come out, you need to have a bowel movement, can't be constipated. You need to be able to give birth to a baby. You don't want to tear and have an emergency C-section. That sometimes happens, but if you can avoid it, we can avoid it. Let's learn how to let things come out. But then we also need to keep things in or let things come in. So for example, we need to hold in our bowel bladder functions, right? But then we also need to let things come in. So we need maybe intercourse to happen to conceive in the first place. So there needs to be a lot of different pieces to the puzzle when it comes to pelvic health. And how are you optimizing all of those things? So it's not that you have one thing and not the other thing that's working efficiently for you. So I teach people how to do that in sessions and how to have that full range of motion and understand where is their pelvic floor in space and how does that connect to the rest of their body and how can they use their pelvic floor while they're exercising in a very kind of controlled environment, and how do they use their pelvic floor also in an uncontrolled environment where they're trying to pick up a really heavy baby that's trying to run away from them off the floor without hurting their back. Things like that. So I have during the third trimester, usually I have a session with all my moms that's just purely for baby related tasks. So it's like rocking, feeding, picking up baby, things like that. Or how can you do that with good body mechanics and not hurt yourself, because you're going to be doing them overnight a million times a day now. And a lot of people will develop these like quick, acute kind of pains from repetitive movements that they're doing that's not conducive for their bodies, because they just didn't know how to do it otherwise. And so I'll teach them how to avoid those things, even not related to the pelvic floor, related to their neck. Or there's something called mother's thumb. When you suddenly overnight have to pick up a baby using your wrist and your thumb in a certain way, you do it over and over again, and you're like, oh, I can't use my hands anymore. So how can you prevent that from happening? So there's so much to learn. I could talk about this like all day long.
I am so excited to have you on. So you do work with pregnant moms, like you have like a class or people like sign up for that. Is this part of Lamaze? Because everyone only hears about Lamaze for birth. Like that's just what you have to do. But I feel like that's what they've been doing for like 50 years. And there needs to be.
Yeah. So pelvic floor physical therapy is it's different, right? Because it's doctors of physical therapy that specialize in movement. And so we're targeting the movement system. So I think Lamaze, from my understanding, has more to do with like birthing, like childbirth education and lactation support, if I'm understanding that correctly, and all kind of other things. And so, and pelvic floor PTs, I personally am not a lactation consultant. I could not tell you if you have, feeding problems, how to get the right amount of food into your baby. That's not my practice. I'm also not going to teach you, a childbirth education class. What I'm going to do is teach you about your own body and kind of all the things that I just mentioned, on how to prevent, dysfunction in your physical body for the birthing parent to you kind of like avoid some of these things.
I feel like I was like, every woman needs to have this before birth.
Yeah.
Every woman needs to have
100%. We're working on that. Hopefully we'll pass some laws soon to make that happen.
Yeah, because you need to be right there with Lamaze, if not a little. For me, I would think a little bit before Lamaze, just because we have this body forever after we give birth, and we need to know how to prevent it, how to optimize it. And I think for so long, we haven't had that chance to really focus on, like, we do a lot when we give birth, and we need some help for those muscles. So, wow.
Yeah, exactly. I think a lot of the times what happens is, in the medical world, we're making sure the mom doesn't have gestational diabetes and preeclampsia. We want to make sure mom and baby is safe and not medically compromised. But I think that there's not enough of, which is exactly what pelvic floor PTs do, is what's the quality of your life. And so you might not die from urinary incontinence, but that sucks. And I would hate for somebody to, have to wear a poison pad for the rest of their life, or feel like they can't get onto a trampoline with their kid, or couldn't run to catch the bus really quick. Those are all quality of life things, not having like painful intercourse. Like, that's, again, you might not die from that, but what kind of life is that if you can't feel comfortable? And there's a lot of the pelvic floor world, we deal with a lot of psychosocial kind of components, because there's so much of, fear and emotions, and just it's very psychosocial when it comes to bowel, bladder, and sexual stuff. And when it comes to pregnancy and postpartum, mom's going through, or the birthing parent is going through, a lot of different emotions and trying to juggle a lot of different things. So there's a lot of guilt of, if I take care of myself and not taking care of my baby for that time, am I a good mom? So I work very closely with mental health, perinatal mental health. I work very closely with lactation support when the mom, expressing to me that, she's having issues with feeding. I work very closely with doulas who will be there to support during the labor. I don't do that. The doula does that, but maybe she can give me information on how the birth went. And maybe there was this emergency C-section. She can tell me a little bit of information about what's going on with the mom that might be contributing to her symptoms. Yeah. So I work with a lot of different providers, and we kind of are hoping that we, like, educating people, like what we're doing on this podcast right now, will get the word out so that more people in different fields can go, hey, that might be a pelvic floor issue, and you can definitely seek out a pelvic floor PT to help you out with that. And people will get into learning more and reach out more.
So women are not dealing with all these issues that they're told that they have to deal with after they become a mom.
Exactly.
And I can see how those taboo subjects, unfortunately, which give us life, also can play into our relationships with our spouses, like deeply, especially all of their areas, like the vaginal area, like any issues that we're having down there, that can affect our relationships mentally, for sure. Okay.
Absolutely. I see tons of people that I'll even send to sex therapists to kind of work out some of the issues that they might be going because of, having a disruption in their sex life because of pain or difficulty with, just coming to terms with what's going on. So a lot of women after giving birth, they're like, I don't even want to see what's down there. I don't want to have anything to do. Just do what you have to do. And I'm like, no, hun, you and I got to work together here. You need to be in this with me. I'm not working on you. You got to learn how to be okay with your body. And I know it's going to be hard. And there are so many people that are going to help you to connect with your body. I'm here. We can get mental health involved, but you got to be confident. And that's step one. So yeah, that's where we start usually.
It's very true. There's a lot of women that I know that I don't think they've ever, like you said, looked at themselves. Like, they don't know what they look like down there at all, which I find just crazy. How could you not know what you look like down there?
Yep.
So, but I feel like that's a part of society that, depending on what age you are, that was just kind of ingrained in us, unfortunately.
Yeah,
So,
unfortunately, I agree with you.
let's see. Oh, this is a great question. I have so many questions for you. Oh, I'm going to go ask you this one first, because I feel like this is a common question amongst moms. And I never dealt with this, but I hear a lot of moms dealing with this, and I'm probably going to mispronounce it. It's diatec. It's like, it's when you're
Diastasis recti.
Yes, that is it. Can you recover from that? Is that, because I see a lot of women that use like corsets after birth, and they said that that helps with that. What do you think about any of that?
Yeah. So basically, for people who don't know, diastasis recti, some people call it diastasis recti. I call it diastasis recti, but that's up to people. It's basically, so you have your six pack muscle, right? So there's two sides of the six pack muscle. That line in between is called a linea alba, and it's just connective tissue. And so what happens during pregnancy, and can also happen for obesity that's non-pregnancy related. So this can happen for males as well who are not birthing babies, is that six-pack muscle and the connective tissue that's in between kind of elongates and expands naturally as a way to make space for the baby. So, it's actually totally fine if while pregnant you have a diastasis recti, happens routinely. The problem is that when you're postpartum, it's supposed to kind of naturally come back into its usual state. But the issue is when it doesn't, and it's also symptomatic, and it causes lower back pain, and it causes pelvic floor dysfunction. The reason why those things can happen is, the six pack muscle goes from the top of the pubic bone up to your sternum, up to the base of your breastbone, right? Like if you were to do a little crunch, you can feel all the way up from the base of your breastbone all the way down to your pubic bone. That's where the six pack muscle sits, and it's the most superficial, the most front of your body. And so if it's elongated and it can't contract efficiently, then what's taking up the slack, because you're not using that front of your core efficiently, is sometimes the back of your core, which is your lower back muscles, and then the bottom of your core, which is your pelvic floor muscles, are taking up the slack. And so they're working maybe double time. And so when you're postpartum and it's not healing efficiently, usually what I'll see is they have like a pooch. There's like a lot of coning or tenting at the front of their belly, like a lot of skin that just comes forward in like a tent when they do like a crunch for moms. And so that is an indication that you might have a diastasis recti. There's also an objective test that pelvic floor PTs can do, where it's basically called like a crunch test, where I have you crunch and I assess the depth and the width of the separation or the elongation of the connective tissue in the middle. And I can give you a diagnosis of how much that is. And then, and it sometimes comes with lower back pain as well. And so what I do is, it's firstly, to answer your question, it's extremely treatable. It's not so much about closing the gap as it is about how much strength are we building from the base layers of your abdominal muscles. So there's layers of abdominal muscles that are behind your six pack. So you're building a foundation with all of those muscles, and then releasing the lower back muscles, and then basically trying to figure out a way that you can optimally move your trunk and use all of your core, which includes the front, the back, the bottom, and the top, in an efficient way, without exerting so much pressure on the abdominal wall. And a lot of times constipation and straining can also exacerbate that, because you're putting a lot of pressure at the front of the abdomen. And so basically diastasis rehab looks like a lot of functional training, a lot of breathwork training, a lot of anterior, posterior, pelvic floor core training, and then very specific exercises and manual therapy that can help to kind of bring those tissues into a more optimal space. And so I know it's treatable in the sense that you can definitely come closer to closing that gap. But the goal for a PT is to make sure that you are strong, stable, have no lower back pain, or using your body efficiently. That's the goal. That's what we want to make sure that you can do effectively.
Do you know how happy I am to have you as a guest? I feel like what you're teaching women is really that they have control over their body, and they don't have to live with all these things that they've been told they've had to live with their whole life, or just have surgery or medication. I really hope that over the years that this is actually spread to, that a lot of other women actually learn about this. So
I hope so too. That's my goal as well.